So we are looking at renal artery stenosis. So it is most commonly seen in older patient, and the most common cause, most cases of renal artery stenosis are caused by atherosclerosis. So most of the cases renal artery stenosis is caused by atherosclerosis, but fibromuscular dysplasia can also cause renal artery stenosis in younger patient. If it is an older patient, it is most commonly due to atherosclerosis. If it is a younger patient, it can be occur due to fibromuscular dysplasia. And other rare causes include vasculitis can also cause thromboembolism, and aneurysm of the renal artery can also cause renal artery stenosis. Then we are looking at the pathophysiology. So what is occurring in renal artery stenosis? So renal artery stenosis will cause reduction in renal perfusion pressure. So renal perfusion pressure decrease होगा, and because of that renin angiotensin सिस्टम एक्टिवेट होगा और जो सर्कुलेटिंग लेवल्स है एंजियोटेंसिन 2 के वो इंक्रीज होंगे. सो एंजियोटेंसिन 2 इंक्रीजेस एंड दिस विल लीड टू हाइपरटेंशन होगा, इट विल लीड टू वेजोकंस्ट्रिक्शन एंड एल्डोस्टेरोन प्रोडक्शन बढ़ेगा एंड इट विल इवेंचुअली लीड टू सोडियम रिटेंशन बाय द रीनल ट्यूब्यूल्स. सो मोर और लेस हाइपरटेंशन देखने को मिलेगा पेशेंट के अंदर. ठीक है. देन atherosclerotic lesions are typically ostial and are associated with more widespread atherosclerosis within the aorta and other vessels, particularly iliac vessel. So remember, it mostly atherosclerotic renal artery stenosis involves iliac vessels particularly, and there is often concurrent small vessel diseases affected kidneys due to subclinical atheroemboli. और होगा क्या इसके अंदर? So as the stenosis becomes more severe, जैसे जैसे वो severe होगा, global renal ischemia will lead to shrinkage of the affected kidney. The affected kidney will be will lead to shrinkage, and many cause renal failure if bilateral. अगर bilateral shrinkage होगा तो it will lead to renal failure, और if unilateral होगा तो single kidney में ischemia होगा, that is ischemic nephropathy. In younger patients, fibromuscular dysplasia is a more likely cause of renal artery stenosis. This is an uncommon disorder of unknown cause. It is characterized by hypertrophy of the media. Media means medial fibroplasia, which narrows the artery but rarely leads to total occlusion. So there is no evidence of causing total occlusion of renal vessel due to fibromuscular dysplasia, but it will definitely lead to narrowing of the artery. It may be associated with disease in other arteries. For example, those who have carotid artery dissections are more likely to have renal arteries with this appearance. It most commonly presents with hypertension in patients aged 15 to 30 years, and women are affected more frequently than men. So fibromuscular dysplasia presents in a younger age, that is 15 to 30 years, and women are affected more frequently than men. So the patient will be female of younger age 15 to 30 years presenting fibromuscular dysplasia, and it can cause renal artery stenosis. Irregular narrowing or beading may occur in the distal renal artery, and this sometimes extends into the intrarenal branches of the vessel. Rarely, renal artery stenosis may occur as a complication of large vessel vasculitis such as Takayasu arthritis and polyarthritis nodosa. But the most common causes, which I think everybody should remember, is atherosclerosis and fibromuscular dysplasia. Untreated atheromatous renal artery stenosis is thought to progress to complete renal arterial occlusion in about 50% of cases. अगर atherosclerotic renal artery stenosis है, and if we are not treating it, it will lead to complete renal occlusion in 50 patients out of 100. But if you have fibromuscular dysplasia, there are very less evidence of it leading to complete occlusion. Definitely it will lead to narrowing of renal artery, but not complete occlusion. Okay, but with atheromatous renal artery stenosis, in 15% cases, it will lead to complete arterial occlusion. This figure increases with more severe degrees of stenosis. If the progression is gradual, collateral vessels may develop and some function may be preserved, preventing infarction and loss of kidney structure. Conversely, at least 85% of patients with renal artery stenosis will not develop progressive renal impairment, and many patients die from coronary, cerebral, or other vascular disease rather than renal failure. Unfortunately, methods of predicting which patients are at risk of progression or who will respond to treatment are still imperfect. So we don't know कि कौन सा patient होगा, उसको कौन सा रिस्क होगा, कितना प्रोग्रेशन होगा, हु विल रिस्पॉन्ड टू ट्रीटमेंट, ये सब हमको नहीं पता है अनफॉर्चुनेटली, एंड दैट्स वाई डेथ आर हैपनिंग. So this is the pathophysiology, means what is happening in the renal artery stenosis. Next, looking at the what are the clinical features. So renal artery stenosis can present in various ways, including hypertension. So first is hypertension. So there will be hypertension, acute pulmonary edema, progressive renal failure with bilateral disease, or a deterioration in renal function when AC inhibitors or ARBs are administered. So hypertension will be there, acute pulmonary edema, progressive renal failure. Progressive renal failure is only seen with bilateral disease. If it is unilateral, it will not lead to progressive renal failure. And there will be deterioration of renal function with, agar we are using AC inhibitors or ARBs, so AC and ARBs are contraindicated in renal artery stenosis, and if we are using it in renal artery stenosis, it will lead to deterioration of renal function. Although many patients experience a slight drop in GFR when commencing these drugs, an increase in serum creatinine of 30% or more raises the possibility of renal artery stenosis. Acute pulmonary edema is particularly characteristic of bilateral renovascular disease. It typically occurs at night and is associated with severe hypertension, often in the context of normal or only mildly impaired renal and cardiac function. Clinical evidence of generalized vascular disease may be observed, particularly in the legs and in older patients with atherosclerotic renal artery stenosis. Clinical features associated with an increased risk of renal artery stenosis in hypertensive patients are summarized in box 15.22. So these are the presentation and clinical features of renal artery stenosis. So there will be hypertension. So hypertension is severe, of recent onset, or difficult to control. Kidneys are asymmetrical in size. So the affected kidney will be smaller in size, and the normal kidney will be increased in size due to compensation. So compensatory increase in size will occur in the normal kidney, and the affected kidney will be smaller due to ischemia. So there is kidneys, asymmetrical kidneys in size. Flash pulmonary edema occurs repeatedly, particularly with bilateral disease. There is a peripheral vascular disease of the lower limbs. There is renal impairment. Renal function has deteriorated in angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers. If we use in renal artery stenosis, it will lead to deterioration of renal function. So these thing is important. So this is the presentation and clinical features of renal artery stenosis. However, given the risk of imaging and angiography in patients with renal disease, further investigation should only be performed if intervention is being contemplated. So these are the clinical features with which patient will present to us. Then what are the investigations you'll do? So when appropriate, imaging of the renal vasculature with either CT angiography or MR angiography should be performed to confirm the diagnosis, but there will be some side effects due to the contrast we are using for MR or CT angiography. Both give good views of the main renal arteries, the vessels predominantly involved, and the most amenable to intervention. Biochemical testing may reveal impaired renal function and an elevated plasma renin activity, sometimes with hypokalemia due to hyperaldosteronism. Ultrasound may also reveal a discrepancy in size between the two kidneys. So a discrepancy in two kidneys, it is seen in ultrasound, which I have told you that the affected kidney will be smaller and the normal kidney will be bigger. Okay, although this is insufficiently sensitive or specific to be of value in diagnosis of renovascular disease in hypertensive patient, so the most sensitive or maybe the most important test is CT angiography and MR angiography. Then how to manage these patients? So the first line management in patients with renal artery stenosis is medical therapy with antihypertensive drugs supplemented where appropriate by statins and low dose aspirin in those with atherosclerotic disease. So the main first line management, which is medical therapy, because the patient is having hypertension, so we will give antihypertensive drugs supplemented with appropriate by statins. So we will give statins if the patient is having atherosclerotic disease. So statins and low dose aspirin is given if the patient is having atherosclerotic disease, which is most common. Interventions to correct the vessel narrowing should be considered in young patient. The problem is in renal artery vessel, means the renal artery is having the stenosis. The problem is in renal artery, so that thing is corrected only if the patient is young, age below 40 years, suspected of having renal artery stenosis. We have to correct the renal vessel stenosis. Those whose blood pressure cannot easily be controlled with antihypertensive agents alone, so we have to treat the cause. Those who have a history of flash pulmonary edema, those with accelerated phase, means malignant hypertension, those whose renal function is deteriorating, in all these patients we have to correct vessel narrowing. But in other patients, if the patient is more than 40 years, so we don't have to correct the vessel narrowing, we just give the antihypertensive drugs, statins and low dose aspirin. So this is important in whom you have to give this intervention to correct vessel narrowing. So these are the patients in whom you want the vessel correcting. Okay, considered in these patients. Okay, next, the most commonly used technique is angioplasty. So we can do repair of the renal blood vessel, that is your angioplasty. So angioplasty is also a surgical management. The best results are obtained in non-atheromatous fibromuscular dysplasia, where correction of the stenosis has a high chance of success in improving blood pressure and protecting renal function. So angioplasty is giving best results if the patient is having non-atheromatous fibromuscular dysplasia. So in these cases, correction of stenosis is very good if you want to improve blood pressure and you have to protect renal function. Then in that case you can do angioplasty. But in atherosclerotic renal artery stenosis, we don't want the extra surgery. We can just manage by antihypertensive drugs, statins and low dose aspirin. Okay, beyond the indications above, angioplasty and stenting is now rarely performed in atherosclerotic disease, as randomized trials such as Astral and Coral have produced no convincing evidence for overall benefit in terms of renal function, blood pressure control or cardiovascular outcomes. These are not affected if the patient is having atherosclerotic disease and we are doing stenting or angioplasty. It is not required if the patient is having atherosclerotic disease, because it is not giving any benefit in terms of renal function or blood pressure or cardiovascular outcome. So we are not doing angioplasty or stenting in atherosclerotic disease. So the risk of angioplasty and stenting include renal artery occlusion, renal infarction and atheroemboli from manipulations in a severely diseased aorta. If the aorta is severely diseased and we are doing any angioplasty or stenting, so it will lead to manipulation, and the manipulation will lead to renal artery occlusion or renal infarction or atheroemboli. Small vessel disease distal to the stenosis may preclude substantial functional recovery. So this is all about the renal artery stenosis. So we have to remember the pathophysiology, the clinical features, the investigations, and the management. And this is the renal artery stenosis, a magnetic resonance angiogram following injection of contrast. So we are giving contrast and we are doing MR angiography, but there are many side effects of contrast used in MR angiograph, which is gadolinium, which is used in MR angiograph, and there are many side effects of it also, but still we have to do it. The abdominal aorta is severely irregular and atheromatous. The left renal artery is stenosed here, as you can see. This is the left renal artery. So this left renal artery is stenosed here. So it is showing that the left renal artery is stenosed, which is renal artery stenosis. And in this, if you are doing ultrasound, it will show left kidney will be smaller in size because it is affected. So ischemia of the left kidney because it is affected, and there is a decrease in perfusion, and the right side kidney will be having compensatory increase in size. Okay, so that is all about the renal artery stenosis. Thank you. So we are looking at renal artery stenosis. So this is the atherosclerotic occlusion of the renal artery on the right side, and you can see the right kidney is a smaller one, and the left kidney will have the compensatory increase in size, so the affected one will be smaller, and you can see the blood vessel is stenosed due to atherosclerotic plaques. This is in fibromuscular dysplasia. So in fibromuscular dysplasia, there will be classical beaded appearance. As you can see, this is classical beaded appearance is seen in fibromuscular dysplasia. It is seen in younger females most commonly, and it will lead to renal artery stenosis. And the other important thing is fibromuscular dysplasia will never cause a complete occlusion of the renal artery, but definitely it will lead to narrowing of the renal vessel. And we can do angioplasty, that is repair of the renal vessel with putting stent. So this will not occur again, but it is not advised in atherosclerotic renal artery stenosis.